Dish. I'm a radiation oncologist here at Mayo Clinic in Rochester. So I wanted to give a brief overview of the topics to be covered today. First of all, I wanted to discuss the rationale for SBRT in the management of prostate cancer. I also wanted to review some of the current data that is being published and are available to discuss the use of prostate cancer SBRT, and then give a little bit of a practical overview and guide about how to perform prostate SBRT and how this is executed in my clinic specifically. So first wanted to start out a little bit just on terminology. We all know that SBRT stands for stereotactic body radiation therapy. And really in prostate cancer, it's been used as a term to cover all forms of ultra hypofractionated radiotherapy for prostate cancer. For the sake of this talk, I will consider SBRT to be any treatment regimen of greater than 5 gray per fraction, given that there is some variation in the literature, sometimes based on the location of the research group or the clinic that is being published on how they use the term SBRT. Often in the literature, the term SABR, or stereotactic ablative radiation therapy, is used interchangeably with SBRT, and for the purposes of this talk, I would consider both terms to be used interchangeably as well. SBRT for prostate cancer is most commonly delivered with photon-based intensity modulated radiation therapy, or IMRT, but it can be delivered with proton beam therapy or other heavy particles, and those things are not necessarily mutually exclusive from my standpoint. Another term that I think is important when looking through the literature or even discussing with patients is CyberKnife. And the CyberKnife is a brand name of a robotic radiosurgery platform that is often equated with prostate SBRT. Many of the early data were exclusively performed on this platform, and so some of the literature actually tries to use that term to describe prostate SBRT and make those two interchangeable. But certainly in the modern era, there are a number of different linear accelerators and other photon-based treatment modalities that can be used to deliver prostate SBRT. So I do think that I typically refer to 4 R's when I think about reasons for prostate SBRT. The first is radiobiology. So there's been a lot of research trying to determine some of the radiobiologic characteristics of prostate cancer as measured by an alpha-beta ratio. While nobody knows what the true answer is, and I'm sure there is some variability from patient to patient and tumor to tumor, the best estimates place this between 1 and 3 gray, and probably between 1 and 2 gray are the most recent estimates. So compared to more rapidly dividing tumors like head and neck cancers or lymphomas, this is a much lower number. Those tumors are often thought to be in the 5 to 10 range. Here we are talking the 1 to 3 range. When we deal with tumors with low alpha-beta ratios, hypofractionation provides an opportunity to potentially improve the therapeutic window by exploiting some of the susceptibility of those cancer cells to large doses per fraction compared to some of the surrounding normal tissues. So this slide shows some of the different dose fractionation regimens that have been and are commonly used for prostate cancer, looking at a number of different 3.0 as being standardly used for most normal tissues, especially those in the vicinity of the prostate, like the bladder and the rectum. And then I've provided some estimates on different alpha-beta ratios for prostate cancer at 2.0 or 1.5. If you compare this to, say, a standard fractionated dose-escalated course of 78 gray and 39 fractions, which certainly has good evidence to support its use. And SBRT regimens of 36.25 to 40 gray 5 fractions can provide significant dose escalation to the prostate cancer cells, while even lowering some of the equivalent dose to the normal tissue from a BED standpoint, or biological effective dose, in the 36.25 example. So this is some of the rationale and why there was early excitement about the use of prostate SBRT in a clinical setting, is this potential to improve the control of the prostate cancer tumor while potentially simultaneously decreasing or at least maintaining some of the risk to the normal surrounding tissue. Resources is another SBRT. The reality is this is not surprisingly, that means lower utilization of resources within the clinic. And then on a larger scale, for payers, which can be a national or insurer, depending on where you live and how healthcare is delivered. This is a paper from the Canadian healthcare system that looked at the cost effectiveness of different treatments, low dose radiotherapy, and really they found that SBRT provided the most cost-effective treatment strategy for prostate cancer, taking into account resource utilization, expected long-term treatment outcomes, both in terms of cancer control and toxicity. So at least in the Canadian system, this was determined to be the most cost-effective strategy when we're thinking about that. Obviously, for resources, the patients and the clinical staff will simply notice that this is just fewer visits for the patient to the clinic. So most SBRT regimens are 5 treatments. Here you can see I've modeled this on an every other day basis, Monday, Wednesday, Friday, following week a Monday, Wednesday schedule, compared to a moderately hypofractionated or conventional radiation therapy schedule, which can stretch into 1 full month or even all the way out to 2 full months of treatment when in the case of a 38 to 44 fraction regimen. So that means fewer visits to the radiation treatment center, fewer appointments for the clinical staff to maintain, less utilization of the treatment room and the treatment machine, less time away from work for the patient and their family if that's something that's important to them as well. So patients do definitely notice this decreased burden on them. And then the final R is something I call rivalries with the robot. The urologists who perform surgery, which is a very acceptable and reasonable treatment for most patients with prostate cancer, we often have to talk to and counsel patients about how our treatments compare to surgery. And I'm not going to go into that topic in great detail today, but when we have a surgery that's often done as either same-day surgery in some locations now or with a overnight stay in the hospital, the time benefit of SBRT can provide a similar amount of burden on the patient compared to, say, a 40 fraction course of radiotherapy, not taking so much of their time. And so I think it was important for SBRT to allow us to offer treatments that maybe had a similar time dependence for the patient when patients are trying to decide between these, so that we can make sure radiation maintains itself as an attractive and effective option for patients with prostate cancer. Once again, not to say that surgery isn't a good option, but we need to make sure we're doing our best to make our treatment hold up as well as possible, knowing that advances are being made in the surgical technique as well. So I did want to 3 published data. So this is the PACE-B study, which was performed primarily in the United Kingdom, but did have some Canadian centers participating as well. It was a randomized study of nearly 900 men with intermediate risk prostate cancer. The comparison and randomization was between SBRT at 36.25 gray, 5 fractions, versus conventional radiation, given either as moderately hypofractionated or standard fractionated treatment. And early outcomes have been published in terms of toxicities. We only, at this point, have 2-year follow-up on this study. Oncologic outcomes have not yet been published, but the data about toxicities is now available for 2 years of follow-up. The totality of the data on this slide showed us that there was slightly higher grade 2 or greater urinary toxicity in SBRT patients compared to the conventionally fractionated patients. This difference was numerically relatively small, somewhere between 8 to 12%, depending on which time point or estimate you use, and transient for most patients, meaning it resolved with time and was not persistent for many patients. Similarly, when we looked at patient-reported outcomes in terms of urinary bother, there was a slightly increased, but not statistically significant difference in urinary bother for SBRT. I would say this is reflective of my clinical experience as well. When you deliver SBRT, you will see a slight increase in what we consider mild to modest urinary symptoms compared to a longer course of radiotherapy. These are often temporary and resolve with time and don't persist in the long term. GI side effects, meaning bowel side effects, appear to be no different in this study, and patient-reported outcomes similarly reflect this. We are eagerly awaiting cancer control outcomes from that study and expect those somewhere between the 5 and 10-year outcome, with the last data being published in 2022. This is a study that does have cancer control outcomes. This is the HypoRT-PC study. This was performed in Scandinavian countries. and was a randomized study of 12 men. So this used a ultra-hypofractionated course of 42.7 grade 7 fractions. So you'll notice this is the one study that uses a non-5 fraction course of radiation therapy, and compared it with 78 gray and 39 fractions. So this is randomized, 1-to-1 between those two arms. Median follow-up was 5 years. You can see on the graph here that failure-free survival was no difference between these patients at the 5-year mark, with some patients having follow-up beyond 5 years, but certainly that is the minority of the study. And understanding with prostate cancer, longer-term outcomes are very important to assess the effect of our treatments. This study was actually a little bit different in that the first one they looked at toxicities, GU and GI were no different, but when they looked at patient-reported outcomes, they did see a slight increase in GI or bowel side effects in the patients receiving the ultra-hypofractionated arm. This only happened at the end of radiotherapy and not persisting at longer-term follow-up, so a very temporary side effect. It should be noted that the technology and techniques used for this were what we would consider to be not quite up to modern standards. 80% of these patients were treated with 3D conformal radiotherapy, and image guidance was variably used on the study. So treatment techniques that I think a lot of us consider to be kind of the hallmarks of modern prostate cancer radiation therapy were not mandated on the study, and likely had some impact on the GI side effects where larger